Hello. How's everybody doing? My name's Natalie, if you haven't met me yet. And this week's another SimWars lecture, another good time. So obviously ACLS last week was a little bit of a jump for maybe some of us that that have been participating in the SimWars content previously. Obviously, study that in your own time, getting ready for the internal comp, review those algorithms and everything. That's going to become standardized for you. More practice, you're going to feel more confident, and we'll go from there. So just a bit of housekeeping things as usual before we get started. So SimWars signups are closed. Obviously we said this a few weeks ago. There have been a few stragglers trying to join us a little bit late, but can you imagine if their first week was ACLS, they'd probably get a little bit overwhelmed. So we won't put them through that. And finally, we said this last week, but please watch the lectures before you attend the practical. Whether it's live right now, later, watch them before you come, and if you're unable to, unbook yourself. Just because the fact that SimWars is a team-based activity, and by you not studying the lectures before coming and being on a teammate with individuals that have been able to study the lectures, you're putting themselves at a disadvantage, and also yourself as well. We're as coordinators, we're putting in a lot of extra volunteer hours into creating this program for you guys outside the normal medicine stuff we're supposed to be doing. My ratio of actual medicine to SimWars is insane, but it's okay, it's fun. But yeah, we're just really passionate about this program, and we want that engagement to be reciprocated by you guys as well, just going forward. So internal comp information for those that didn't watch the lecture last week. So our dates are Thursday, November 17th, and Saturday, November 19th. You're only eligible for the internal comp if you've been able to attend at least 4 practicals. And these signups for the internal competition, and this is the important part, so tell your friends, anyone who's participating in SimWars, that these signups are going to be open till Wednesday at midnight. So afterwards we will be closing signups. The reason for that is because you guys probably want to know who your internal comp team members are, right? So we want to get that information to you guys as soon as possible. We're assuming that you're going to want to be able to practice with your teammates and everything before the internal comp next week. So yeah, that's why unfortunately there's a little bit of a big deadline on this, because remember last week we said signups are open for a week. We've extended it a few days just for your benefit. But, and then yeah, if there are more demands than spots, we'll do it based on attendance. Here's the QR code. Screen it, capture it, whatever you got to do to come and sign up. But before you do so, just remember, phase 2 is a very significant time commitment. So if you're a person that has a lot of other extracurriculars, involved in a lot of other societies and everything like that, just kind of think about, am I going to be able to commit to the time that this requires for both myself and my learning, but also your teammates as well. The attendance isn't as chillax as it is in phase 1, just because you're with your team and you guys are a unit moving forward through the curriculum. Other things, so for next week, obviously because next week is internal comp week, there's no official practical session next week. But what we're going to do is on the Tuesday, I apologize, for those of you that have, for example, missed a session and want to catch up on some things, or anyone who just wants to come and practice some of those skills that you did previously, we're just going to have a general drop-in session on the Tuesday. Come on in anytime. We'll have all the equipment out. We'll all be there answering any questions that you guys have. So come on by. And then in terms of the lecture, our final one is next Monday. So obviously for that lecture, there's no practical session for that lecture because the times are being taken up by the internal comp. That last lecture is secondary surveys, so systems-based secondary surveys, kind of your RCSI, OSCE stuff. So obviously, because we don't have a practical with this, we're not expecting your knowledge of this to be as concrete as the other SimWars things that we will be assessing in the internal comp, but at the same time, we do still expect, like we do every week, that you watch that lecture beforehand, because obviously that's to your benefit and to your success in the internal competition. Does anyone have any questions about internal comp stuff or logistics of SimWars at all before we get started in the lecture today? Or any questions online too? Excellent. Okay, we'll just get started. You guys can ask us at the end too if you have anything else. Oh yeah, finally, we need volunteer patients. There's a lot of acting involved, from the patient perspective in phase 2. So if you're not interested in signing up for the internal comp, definitely sign up to be a patient with us. It's a good time. all our contact info. Bada bing, bada boom. So, IMIST-AMBO and ISBAR. If this means absolutely nothing to you and it's a bunch of gibberish, that's okay, because that's what today's about. We're gonna get there, fam. So, disclaimer as usual, we're not RCSI. You know the drill. So far we've done a lot of treating people in the emergency department, but this is not always the last place that people end up. Sometimes we're able to see a patient in the ED, treat them, send them home, see you later. But realistically, this isn't always the case, and sometimes they're gonna have to send people to other departments or facilities in the hospital. So for certain patients in the SimWars perspective, we're gonna want you guys to start thinking about, as you're getting to the end of that scenario, after you've addressed your ABCs, start thinking about, okay, where is this patient going, and who am I sending them on to for that further care, and we're gonna expect on our end to see your guys' sort of thought process on that. And for those that have been saying, what the heck does the runner do? This is your week to shine. So, you guys know it. Let's go through it. Scream them out. Thank you. Yeah. 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 Iconic. Thank you. I know you guys probably roll your eyes every time that slide comes up, but it's what we do. This is SimWars. This is Emerge. You got it. You got to know this, or I don't know what we're doing here. So, the first little acronym that you saw there at the beginning of the lecture is IMIST-AMBO. So this is a tool used by paramedics to give handoffs to the emergency department when they arrive in the ED with a patient. And the paramedics that you guys come into contact with are going to expect for you guys to know what this tool is and how to engage with it. So first, we have identification of the patient. So for example, this is John Smith, a 55-year-old male, coming in with an M, so a mechanism of injury or medical complaint. So that John Smith may be coming in with a complaint of acute crushing central chest pain. I are injuries or information related to that complaint. So Mr. Smith has had this chest pain for the last 30 minutes, radiates to the left side of his jaw, associated with shortness of breath on exertion. S, signs, those are the most recent vital signs that would have been taken in the ambulance by the paramedics. So for example, for John, his blood pressure could be 130/80, heart rate 95, rest rate 20, O2 sats 92% on 2 liters of oxygen by nasal cannula, temperature 36.5 degrees. T, so that's treatments by the paramedics and trends that they would have recognized en route to the hospital. So for example, for John here in the ambulance, we may have given him 325 milligrams of aspirin and sublingual nitroglycerin spray. And other than that, trends have been stable. So that's the IMIST. So you can see here, like when you look at M and I, so this kind of breaks up whether it's a trauma-related situation or a medical complaint. So you see M, we have mechanism of injury, and then injuries. And then on the sort of clinical medical side, we have the medical complaint and the information related to that complaint. Any questions about IMIST so far before we go to AMBO? Are we good? No? All right, so that is IMIST. So then at that point, there's a pause. And at this point, we've gained all the essential medical information, but this pause now allows for the people in the ED treating the patient to ask any questions to the paramedics about the patient to further guide clinical management decisions. So like, for example, if a patient comes in and it's a trauma patient of an individual hit by a city bus, what type of information may you guys want to know? Anyone can say anything, maybe? Put out any ideas? Patient's been hit by a bus. What do you want to know? How fast is the bus going? Absolutely. It's going to be really different if the bus was stationary versus going 100 kilometers an hour. Anything else?
How long since he was hit?
Sorry?
How long since he was hit?
Yeah, absolutely. How long? Was this like right away, or have they been sitting on the pavement for quite a while before the ambulance was able to get there? Anything else? Yeah, any witnesses? Absolutely. What about like, what circumstances was this person in? Were they a pedestrian? Were they on a bike? If they were on a bike, were they wearing a helmet? How did they land when they got there? Little things like that, that's just gonna give you an indication of sort of those first little clinical management decisions that you gotta make. So yeah, at that pause, so after you've done that, That's also a natural point where the patient would be transferred from the ambulance stretcher into the hospital bed itself. So for example, typically what would happen is the lead paramedic would come in, they bring the patient, they say, okay, hi, I'm so-and-so, I'm gonna go, and they go through IMIST, and then they'll say, does anyone have any questions? Yes? No? Okay. Then your team lead will say, all right, everyone, let's move the patient. And the ED team will move the patient from the stretcher into the hospital bed and continue care from there. So then what happens there is like, ED team will move the patient, and then afterwards the ED team will assess the patient from the ABCs. After the ABCs have been initially assessed and taken care of, then you have someone in your team round back with the paramedic to go through the rest of AMBO. The silliest thing you can do as an ED team is go through IMIST, pause for questions, and then go straight to your patient and get on the care of them without completely forgetting about the paramedic standing in the corner ready to give you more information about the patient. Because they will wait there for you because they won't interrupt typically because they're assuming like, hey, they're dealing with the ABCs, I'm gonna let them figure it out. Unless they're blazed and eventually they'll start. But maybe in SimWars, we'll be testing you to say, hey, you gotta use them, you know? So yeah, AMBO, that's the rest of the information. So still essential information. This is just information that can wait a little bit longer in terms of that clinical management decisions. So allergies, medications, background on like the patient's medical history or other information, and then you have O, which is your other information regarding the scenario.
So would you, any relevant medications, say for example, it's a MI, that'd be done in IMIST, and then everything else would be done in AMBO?
Yeah, exactly. So yeah, like, so for example, like the situation we were saying earlier, you know, if we have John coming in with a potential MI complaint, you know, we could say for A, Mr. Smith has no known drug allergies, medications, he's currently taking metformin and atenolol for his type 2 diabetes and hypertension respectively. Mr. Smith's wife has been informed and she's en route to the hospital now. Like that's sort of like some extra information that you might get there. So that is IMIST-AMBO. Any other questions about that? Yeah.
So like how far into the ABCs are you supposed to, as in like you just, the team leader gives the people instructions and then you go back to the paramedic and the pause for questions, or are you kind of doing some initial instructions and then going back to the paramedic?
Yeah, so I think it'll definitely depend on the situation and the patient that's in front of you. But I think, you know, especially just if you're making those initial assessments of ABCs and maybe those initial sort of clinical decisions on ABCs, you know, if the airway person's, you know, licking the mouth, making sure they're patent, maybe giving some oxygen if they're a trauma patient, if circulation's getting the monitors on, et cetera, like those sort of initial things can definitely happen. It's not a requirement that like, hey, we do this and then talk to the paramedic. It's more just the fact that your team might be busy and you're all hands on deck to that patient. And it might be a few minutes or a few seconds before someone's available on your team to be able to round back to the paramedic and get the rest of that information. So it's not like a concrete rule, but just if you have someone with a free set of hands, really good idea to get them to talk to the paramedic. Anything else? Are we good to go? Yeah?
So paramedics bring the patient in, they give the IMIST,
Yeah?
and then they wait for somebody to take the AMBO from them.
Exactly.
So that's where the runner comes in.
Fabulous, yes, exactly. So typically, yes, the runner is the individual that would be taking this sort of AMBO history, but also that's not necessarily concrete. It's just whoever on your team is available to speak with the paramedic at that time. It might be the runner, ideally that's what the runner's for, but if the runner is, you know, helping the assessment person doing a whole trauma assessment, they may not be the person to take that. So for example, on your SimWars team, who are some positions that definitely should not be doing the AMBO handover information? Airway, fabulous. Anyone else? Circulation maybe, not ideal, but who's like someone that's definitely not moving? Yeah. So team lead and your airway, those people are not moving from their respective positions. Everyone else is a little bit more flexible in their roles. But yeah, great job. Okay, so we're gonna do a little bit of a practice IMIST-AMBO. So I'm gonna give you one, and then I want you guys to think about sort of that pause for questions there, some sort of questions you might wanna ask me. All right, so hi, I'm Natalie with the Dublin Fire Brigade. This is Jane Murray, a 21-year-old female complaining of shortness of breath that has been going on for about an hour. It started suddenly when she was sitting watching TV at a friend's house. Last cited vitals were O2 sats 92% on 15 liters of oxygen by non-rebreather mask. Rest rate is 30, labored, heart rate 110, sinus tachy on the monitor, blood pressure 100/70. All vitals have been solid the whole time, no trends up or down. Oxygen helped her symptoms a little bit, but not too much. Any questions you might want to ask me?
Any prior medications in asthmatic?
So that's a little bit of the AMBO, yes. That will come with AMBO.
What about IMIST?
Sorry, the past medications and everything like that.
To ask you about IMIST.
So if you have the structure, and I've just given you the IMIST part, and you know that the AMBO part is about to come, you're going to ask me AMBO questions that would fall into the AMBO part. No, right? So there's relevant questions we can ask in the middle that aren't necessarily allergy medication background or other, right?
So I could ask, like, when was the onset of the symptoms? How long ago did it start before she called?
Yeah, that's a great question. So for those online, like, onset of symptoms versus when she called the ambulance, like what's the timeline for that? That's excellent. Anything else? There really aren't wrong answers here. You can think of anything. I'll give you a hint. I think over many weeks, we've kind of been stressing, a lot of people have been looking at the monitor, not the patient. So if a 21-year-old lady is coming in and you know her rest rate, you know her O2 sats, you know she's got shortness of breath, is there anything about the patient maybe you want to ask? Yeah?
If she looks well.
Yeah, like what does she look like? Absolutely. Is she sweaty? Is she, pale, whatever? How about,
Are there any signs of shock?
yeah, you could ask about that. I'm more thinking like something really simple as like, what do her breath sounds sound like? With a stethoscope, like, is there wheeze, is there stridor, is there crackles, like what's going on there from like a classic OSCE clinical standpoint, besides the monitor. I also said O2 sats 92% on 15 liters of oxygen by non-rebreather. What would be another thing maybe about that you want to ask?
What is it off the mask?
Yes, what is it off the mask? What was it like before we gave any sort of airway treatment in the ambulance? Absolutely. And another side to that, what treatments did we give in the ambulance? Did you give her anything? Or have you guys just, stabilized her and you're bringing her in, and now in the ED we'll start that treatment? So yeah, these are just little things to think about. Again, there's no real right or wrong answers when it comes to the questions and stuff. Just think about asking information that is actually valuable to you in terms of those initial steps in your ABCs. What's going to help you a lot in terms of those first clinical decisions. So, okay, if you ask me those questions, I would now give you her AMBO. So in terms of drug allergies, she's allergic to penicillin. Environmental allergies is pet dander. She takes Symbicort and salbutamol for her asthma, which according to Jane has been poorly managed recently, and she's needing to use her inhaler more. Patient also states that her friend, whose house she was at when this started, had a cat. So you can see how like the rest of the information is still important to kind of figuring out your differentials, but they're not absolutely essential to like, okay, like what am I going to be doing in those first 30 seconds in terms of addressing the ABCs? Does that make sense? Any other questions on that? Are we all good? Fabulous. Okay, so this is an example here. When you're reviewing the slides, you can kind of go in on your own time to just sort of see what an IMIST would kind of look like. But yeah, that's just for your reference. So now we'll go through ISBAR. So this is you now. This is you as an ED doc, SimWars participant. This is your time to shine. So instead of the paramedic transferring the patient to you, you are now taking that patient and transferring them to another department in the hospital. So ISBAR is a tool used by all clinical staff, not just the ED, to structure patient handovers. So I didn't know this point until I reviewed the lecture before teaching it, but bonus points. This is Blaze's information. Does anyone know the origin of ISBAR? Like where it came from? When it wasn't called ISBAR, it was just SBAR.
Not like the grocery store.
SBAR. SBAR. I don't know if people online can hear me very well.
Aviation.
Not aviation.
That would be right 99%
99.
of the time, my guy.
Wait, Grant, online you were typing. Did you have a guess?
Let's go with
Oh,
Given one of the mantras of this organization.
Someone online has a guess.
Jenna said military. We're getting,
That's correct.
yeah, that's correct. Does anyone know specifically?
It's wild.
It's wild.
Parachutists.
Maybe.
You're right.
The Navy.
Yeah. So it was like the U.S. Navy to ensure precise communications between nuclear submarines.
So reactor handovers. When the nuke officer on a submarine would hand over to the next launch officer, that's the state of the reactor. So that would be submarines and aircraft carriers, right? The only two nuclear powered vessels in the Navy arsenal. So that's where that comes from. We steal shit, man. We don't come up with stuff.
So you know how we were talking about like to see that people are watching the lectures and we have a password? It's going to be submarines. So that's the password this week. It is now submarines, if anyone asks. Okay, so perfect. So this is ISBAR. So you'll notice that there's going to be a lot of overlap in some of the steps of ISBAR when we go through them. You know, it's okay, it's a communications tool. As long as you're saying this stuff, it doesn't really matter whether you're saying an I or S, but we'll go through it. So I, identity, S, situation, B, background, A, assessment, R, recommendations. So we'll go through them each one by one because this is really stuff that we're going to ask you guys in SimWars to know how to use this tool, and you will be assessed specifically on this. So ISBAR, the I part, that's identity. That's who's involved. This is not just who the patient is, this is also who you are. So identify yourself, identify your position, and then identify the patient and their problem. You also want to know on the other end who you're speaking to and who they are. So did I reach the department I intended to reach, or am I on the switchboard? Did I call the wrong number? Am I speaking to the intern or the consultant? Because the way you formulate your communications will be very different based on who you're speaking to. So yeah, hi, my name is Natalie. I'm one of the eMERGE docs. I'm calling about so-and-so who has shortness of breath. Here's their information. Just a little, hey, here's me, here's them, who are you? So S is the situation. So what is happening right now and why are you calling? So the first thing you're going to do is tell the person on the other end of the phone what you want from them, why you're calling, and the next action you want them to take. So because the individual on the other end of the line needs to know how urgent your request is. So do you need them to immediately drop everything they're doing to come down and, for example, intubate a patient? Or is this this person needs to eventually go onto the wards, and if it takes a few minutes, that's okay. They need to know the urgency of what you're asking. So for example, I'm calling because this person has ST segment elevation on ECG in the anterior septal leads, and I'm referring for PCI. Like a real quick, just, this is what's going on. But yeah, so then you would give sort of vital signs of the patient, hopefully after you've stabilized them as best you can. Again, kind of up there, as I hinted in the last sort of IMIST-AMBO, up there you can see both oxygen saturations and oxygen delivery. Again, because that's a huge difference. So like if someone's on 99% oxygen and they're on BiPAP versus 99% oxygen and they're by themselves, like they're good to go. So clarifying those things. Relevant assessment findings. So for example, if you're calling surgery, you might say we have a positive EFAS scan. And then in terms of ongoing treatments, what have you done so far for this patient in the ED? Did you activate massive transfusion protocol? Are you giving bloods? Did you give TXA? Those little things, so that they know on their end what you've done and what they may need to do on their end in order to take care of this person. So B, background. So brief history of presenting illness and relevant past medical history. So none of this RCSI, like 10-minute taking OSCE stuff with a lovely long social history about, oh my goodness, tell me about the breed of dog your uncle has. Like no one cares. It sounds lovely, but it's not relevant for a handover at all. So like surgery doesn't care if they live in a 2-story house. If they're extremely short of breath, then maybe absolutely include okay, pack your history, or if you're worried about decompensated liver failure, then absolutely alcohol history may be relevant in that. But again, just tailor the information that you're providing based on the patient presentation in front of you and who you're talking to. So like a 60-year-old patient presenting with chest pain, and at 15 they had an appendectomy. Cool. Not relevant. Nice, but we don't care. Thanks though. So yeah, and then prior treatments. So again, this is kind of a little bit of overlap from the last one, but prior treatments can be what the patients took themselves before coming to the emergency department if they tried to self-manage whatever was going on, what the paramedics did in the ambulance, and then what you yourself did in the ED before transferring off this patient to someone. And then A is assessment. So this is what you think the problem is. So from a SimWars perspective, we are not trying to trick you. You know, most of the scenarios that we're going to be presenting you with from the ED standpoint are the obvious things, the basic things, you know, the essential knowledge things. Like if you think your patient has a pulmonary embolism, based on your clinical knowledge and your assessment, they probably do. But of course, if you don't know what's going on with the patient, if you're, for example, calling someone for a consult, they're a little bit confused on management and where to go next, that's obviously acceptable too. You know, just know that we're not, at least from a SimWars perspective, when we're giving you the scenarios, we're not trying to trick you, but when you're actually out on rotations and you're out in the ED as maybe a medical student or intern and stuff, you know, it's okay to kind of collaborate on like sharing your differentials with someone. Any questions so far on everything before I keep going? Or am I good? Okay. So, and then finally recommendations. So this is both a recommendation that what you want the other person to do, that you're speaking to on the other end of the line, but also what you think they may want you to do to help kind of make their life easier once the patient is transferred to them. So, and also in regards to telling them what you want them to do, like hand it to them on a silver platter, like make it really obvious. Like this patient has ST segment elevation, I want you to take this patient for PCI. I'm taking them to the cath lab, this is what I want you to do. Because realistically, doctors are gonna choose the lazy option, if they can. So yeah, and also recommendations from the department that you're sending them to is also a really sort of effective strategy, maybe in SimWars, wink wink, if you're wondering if maybe you missed something or forgot something that you were supposed to do. So, you know, like maybe you call them and they may remind you of a treatment option that you could have done previously that maybe now you can do. But yeah, so that's ISBAR. Any questions on ISBAR overall before I continue? Online, we're good? Excellent. Oh, no? Excellent. So, so some of the things that you may use ISBAR for. So there is kind of a difference between a consultation and a referral. So a consult is when you have someone in another department or another facility in the hospital and you want them to come to the ED and see this patient. Like or you're just having a phone call with them, like I need some advice. I don't know what to do, come help me out, or I need you to see this patient in the ED because I'm kind of, you know, want to know what to do next before we send them elsewhere. This can be either like for a procedure or again, if you're confused on next steps. A referral is like as a proper handover, like I treated this patient in the ED, I am all finished with them, it is now your turn to take them over. So that's like, you know, it'd be referring them to surgery or like up to the wards for medicine if they need to be treated more long-term. But yeah, so like if they're unsuitable for discharge, all that stuff. Is that clear? Any confusions on that? Fabulous. So reasons for a consult. I don't think it's cheating if we tell you that it is a very common occurrence in SimWars that you will be calling anesthesia to help you intubate a patient. This will likely come up in the practicals this week, so a little hint hint, know what to do for this. So anesthesia is a very common consult that you would be calling if you're having difficulty securing the airway. You may hear the term like less than 8 intubate. So if their GCS is less than 8, that is an indication that you need some senior help from an airway management perspective. Anesthesia may also get central line access. So for example, if you can't get IV or IO access, they'd be helping out there. Surgery may come in for like a pre-assessment, or like again, like technically when you're calling massive transfusion protocol with the labs, that's a sort of ISBAR handoff. It's not as intense and as like concrete as a typical ISBAR handoff that you'd be sending to a consult, because obviously you're saying, I just need blood, get it up here. But it's same principle. So can you guys think of any other sort of examples for a consult besides anesthesia, surgeons, or anything like that, that maybe you want to ask someone for some advice or have someone come down to the ED. Ortho, yeah. Absolutely, they'd be coming down for ortho things, whatever those are. Bone shit.
There's one that I know some of the groups I've seen have definitely done, and it's not like it helps you, but it's not medical. That's a good method.
Cardiology is a really good one, definitely. You know, if, okay, I'm seeing some weird squiggly lines on the ECG, and their symptoms are a little curious. I don't really know what I'm doing. Come help me out, cardio.
I've seen a few groups call for imaging, portable X-ray.
Yeah, absolutely. Radiology, absolutely. You can't just like send the patient to radiology. It's ideal. Wouldn't that be nice? But you gotta call them first before you send them down. Yeah. Anything else? Did you say neuro? Yeah, absolutely. For example, if you're worried about a patient that may be presenting with stroke symptoms, absolutely, your stroke docs are going to come right down to the ED to do that stroke assessment there. Absolutely. Again, there's no wrong answers. There's lots of different, like, that's why hospitals exist. They all come down eventually. But yeah. So that's all consults, people coming into the ED. In terms of referring patients, like I've finished my initial care of this patient, where am I sending them next? The places you'll go. Here's some examples of where we'd send these patients. So, you know, okay, what type of patients are going to theater? Who's going to the OR? Trauma, yeah, absolutely. Anybody else? Yeah, absolutely. Appendicitis. They've got like an aortic dissection. There's a lot of different things that they're going for surgery for, absolutely. Interventional radiology, if anyone has any ideas? Or endoscope? No? Yeah, I think so. You guys know better than me. But yeah, and then like, for example, like PCI, that's your cath lab. So that's where your patients needing some stents for their MIs would be going. ICU, obviously, if the patient needs more intensive care, especially from like if they're getting intubated and they're going to be kind of long-term taken care of for a few days, absolutely ICU, or the step-down ICU. It's another one, or like another hospital department as well. You know, okay, they're stable, not quite stable to go home, but we can send them to the wards, that sort of stuff. So when to refer, like obviously we said in SimWars we want you guys to start thinking about that near the end of your like 10-minute scenario. But make sure when you call, you've done all the right things on your end to make that a successful referral. So make sure you've ordered all those investigations that you're supposed to. Make sure you have, like if you're referring them for surgery because you're suspecting internal bleeding, you better have an EFAS scan done before doing that. You know, if you are calling massive transfusion protocol, you better have sent a group and match before doing so. Can't do anything in terms of massive transfusion without knowing your blood type of your patient. A little caveat to that is to not, don't wait around for investigations that you've ordered that are outstanding if they're not going to make a difference to the clinical management of that patient. So if you've got a patient with on ECG, ST segment elevations, crushing central chest pain, they've got all the symptoms of an MI, and you don't have the troponin back yet, just send them. You know, it's like that troponin's not going to really make a difference in terms of the clinical management of stuff. You know, for example, if you've got a patient with sepsis that needs ICU, you've sent the blood cultures. Blood cultures take days to get back. Better not wait for them. That would be awful. So little things like that. Just make those judgment calls that, okay, we've done the investigations, they've been ordered, we've covered our ass on that end, but we can kind of make those next moves towards transferring that care. And then that department will have those results when they come. Any questions on any of that? Good. Referral timeline as well. So obviously SimWars is 10 minutes. We're only asking you to keep your patient alive for 10 minutes. And realistically, we are artificially speeding things up for you because in the real world, those things take way longer. So if you guys are sending bloods and a chest x-ray, we'll probably give you that within 2 minutes. That would be wild if you got that in real world. So just know that it's not fully indicative of what's actually happening. So these are the sort of rough timelines for things in Ireland specifically. So yeah, realistically in the ED, you know, you gotta keep your patient alive for at least an hour. So 6 times what you guys are doing. But I feel like you guys could do it. So yeah, and then honestly, like this whole thing about ISBAR, IMIST-AMBO really comes back to everything that we talked about in the very first lecture. That's your team dynamics and that's your communication skills. So, you know, any of the things that we kind of listed that were essential for effective team communication in the very first lecture, does anyone remember any of these things? Closed loop, love it. Anything else? It's a lot of labels for things that hopefully you are naturally doing as an individual. You know, if you're in medicine and you're not communicating with people effectively, I don't know what we're doing, right? But I'll put them up for you. So yeah, closed loop, clear messages, clear roles, knowing your limitations, that's really important. Knowledge sharing, very important. That's the whole point of this. Constructive intervention, reevaluation, summarizing, that's always okay, let's go back to our ABCs. And mutual respect, most important, for yourself, for your teammates, for the docs that you communicate with, for the paramedics that you communicate with any members of your healthcare team. Essential. So just kind of going back and reviewing all of these from an IMIST-AMBO ISBAR standpoint, closed loop communication, absolutely essential. So expect a read back, either with the paramedics or who you're referring to. So for example, if you're calling anesthesia about a difficult airway and you want them to come down and intubate a patient, and they say, okay, I'll be down there in 3 minutes. You can say, okay, just to confirm you're able to come down and intubate the patient, and we'll see you down here in 3 minutes. And they'll say yes. Little things like that. So keep that closed loop communication going, not just with your team, but who you talk with on the phones as well. Yeah, timing and orders. That's exactly what we did. Clear messages. So yeah, concise language. Also, it's okay to assume that the person you're talking to on the other end is a doctor, because, you know, we'd be in a hospital. That makes sense. So you can use medical terminology. That's okay. But also, you know that other specialties have different abbreviations for things. So maybe just, it's okay to kind of say the full thing if there's a little bit of questioning. Ophthalmology is the worst.
I tried to talk to an ophthalmologist. It's the fucking worst. They don't do left eye and right eye, they do like OD and OS.
OD, OS, oh yeah.
What the fuck is that?
For those online, we're complaining about ophthalmology. That's what we're doing.
Just, yeah,
Yeah, no.
the worst.
Eyes are weird. Clear roles. So again, so who makes the call for the referral? We kind of said the runner earlier, but why is this relevant? So it takes time to do referrals, and it takes time if maybe you're making multiple phone calls during a scenario. You know, that person that runner, if it is the runner, again, situations change, but that runner might be calling for massive transfusion protocol and then immediately calling surgery right after to say, like, this person's going to surgery. So it takes time. So you want to make sure that you're sending people to do this that have the opportunity and the capacity to step away from the patient for a few minutes. Again, that's not always the runner. We're saying the runner is doing it, but sometimes, you know, if they're really busy doing a DCAP BTLS trauma assessment, maybe someone else on your team is able to do it. Kind of like what we said before, the roles that can't make referrals are airway and team lead. Definitely, those roles don't move, but everyone else can kind of bleed into a little bit if anyone needs help. Another thing to kind of think about is, okay, so let's say we call anesthesia and we want them to come down and intubate our patient. What's going to happen when anesthesia enters the ED and joins our team? Well, where's anesthesia going to go? Airway. Anesthesia goes to airway. Thank goodness, because we're doing a bad job of it right now. Not because we're doing bad, but we need a more senior anesthetist to kind of help us out. So what's going to happen to your airway person when anesthesia comes in? What's their role going to be? How are you guys going to get your anesthesia person to kind of step in, and where's your airway person going to go? Are they going to help with circulation, going to help with assessment? Are they going to start making phone calls? Who knows? But that's something that maybe your team, you guys need to discuss before they get down there. And also it is important to know your limitations. So obviously if someone, like a doc on the other line, is asking you to do something that you have no idea what to do, tell them that. So if you're calling a cardiologist and you're like, oh my goodness, my patient has cardiac tamponade, they're like, all right, and you're the intern, and you're like, okay, go ahead, do pericardiocentesis. Get a needle and go. You'd be like, you're crazy. I'm the intern. I'm not doing this. So tell them that, respectfully, but tell them that, because it's okay. Tell them no way.
Their response might be disrespectful.
Right.
Dude, all we can do is teach you guys how to be respectful. We can't go out to the hospital and correct every single piece of shit it's not, so good luck.
Yeah. There may be dinguses out there, but Emerge, we're always chill. We're chill vibes. We help anyone and everyone. We're having a good time. Why do you think we're here? SimWars? It's a good time. So knowledge sharing is the biggest thing. Again, the ED is a team environment. You are working with your team. You don't want to like take your little information that you know about the patient and put it in your pocket and save for later because you know it. If you know the patient's allergic to penicillin, oh my goodness, vocalize this to your team. Vocalize it to the people that you're transferring the patient to, and little things like that. If you're not knowledge sharing with your team, with the patient too, don't forget about them. And those that you're referring to, like, it's not going to be a successful recess. Kind of what you were saying earlier, that yeah, sometimes there are people on the other end of the phone that are absolute dinguses. You know, we're not all lovely. We try to be, but we're not always. So if you're ever in a situation where you are speaking to someone that maybe is not being as constructive in those interventions that you want to, you know, listen to their concerns. But if you agree with them, you know, state that and say why, you know, what your thoughts are. It's okay to have like a constructive conversation about next steps with this patient. It's possible you may need to call, you know, have a conversation with their senior, or you may have your senior talk to their senior, you know, whatever needs to be done to ensure your comfort and your like comfortability with your role in the ED. So yeah, that's okay. Again, reevaluating and summarizing, this is also really important. Like, so for example, in the scenario I was giving earlier where your runner might be on the phone on massive transfusion protocol and they may be on the phone with surgery, like your runner may have been on the phone a full 5 minutes of your 10-minute scenario, and they come back and they're here to give you help, but they have no idea what's going on. So not just for your runner, but for all of your teammates, it's really good to, you know, double check, reevaluate, and summarize. Go back to your ABCs. Anytime, you know, you've given an intervention to a patient, anytime a clinical decision has been made, you know, after a phone call, you know, just to get all of your teammates back on the same page so everyone's able to make those next steps together in the clinical management. So yeah, always go back to the ABCs. It's what it's about. It's at the beginning of every lecture. And again, mutual respect. We stress this a lot, but yeah, we do what we gotta do. All healthcare professionals are stressed unless they're dermatologists. So maybe they're having a bad day. It's not your fault. Maybe other things are going on. Maybe we're having a bad day because it was a really stressful recess. It's okay. We're all here to be kind to one another when we can. So, and I kind of hinted at this earlier, do not forget the patient. If you're sending the patient somewhere, they better know where they're going, as opposed to just like taking them on the hospital bed and saying, see ya, driving them out the ED and they have no idea what's happening and going on. A lot of the scenarios that you guys have been introduced to in phase 1 have been obviously those like CPR dummies, Little Ann. We love Little Ann, but you also have real patients when you're doing SimWars. In the internal comp, hint, hint, there might be actual patients that you're dealing with that you're gonna have to speak to and converse with. So don't forget about them. It's not just a body on the bed, it's a person. So let them know what you're doing, let them know what you're doing to take care of them in the ED, where you're sending them, answer any questions they have. It's their health and their care that you're ultimately treating. So make them feel in the loop.
Take them to a real hospital.
Huh?
You should take them to a real hospital.
Oh, true. We got a note saying you should take him to a real hospital instead of SimWars. But so TJ is one of our lovely EM tutors. He's actually coming to the session this week, so I think if you're on Saturday, you guys will meet him. He's an icon. So this was kind of a pointer that he gave us as coordinators to, when you're doing an ISBAR handover, formulate what you say based on who you're speaking to. So your ISBAR should look and sound different depending on what physician you're calling on the other end of the line. So TJ has, this is not, scientific at all. This is TJ's doing, but it's great. That there are different types of doctors. So there's those that are open. Those are people that are social and want to help everybody. There's those that are guarded. Those are people that your patient needs to meet certain criteria in order for me to accept them. You've got your direct people that want all the facts, the essential facts right here, right now. And then your indirect people that want all the little teeny tiny details and everything. So emergency med, we are open and direct. We want to help everybody and we want the facts real quick. Surgeons are also direct, but they're more selective in terms of who they can take on, obviously. Psych, very open and very indirect. They want to know anything and everything. But realistically, again, these are stereotypes. They don't always meet the stereotypes, but the reason why it's like this is because this is the information that each of these professions need. So, psych, absolutely, they want to know all the details. If you have a patient coming in with suicidal ideation, they absolutely want to know what are the circumstances leading to those thoughts. Do they have a plan? Do they have the means to do so? What kind of risk are we looking at? They want all those details. So, as much as this is a meme, respect that too. And then obviously your medics, like your medicine docs, your internal medicine, they're like classic Dr. House. Want to investigate anything and everything, but maybe not everybody. And here's my meme that I've added. So just know, again, this is all funny and everything, but again, not everyone fits these stereotypes, so just know that. But yeah, just a little thing to think about in terms of your ISBAR handoffs, that it might be a little bit different depending on who you're speaking to. And that's it. Does anyone have any questions about anything we've covered today or about the internal comp now that we've gotten to the end of the lecture that we can answer before we let you guys go for the night?
We had one that just got answered online, but the question was, does the referral process change if you're sending or referring to a different hospital? So you need to go outside of the facilities based in your hospital. Blaze worked on this answer, but basically it doesn't really change that much and it doesn't come up in SimWars. But to know for a life, number one, it will just take longer because they need to find a bed at the separate hospital. And then number two, there may be a second phone call required, not only to the hospital, but then to someone who can get them there, like an ambulance dispatcher. That was just something that came up.
Unless you want to make them walk.
A question that I had when I did this lecture, so maybe Natalie, you can talk about when you call for referrals or consults in the context of SimWars, what is the realistic level of help that you will expect? So we have a friend who called anesthesia many times in his scenarios last year and was disappointed they never showed up.
Oh. So for those that didn't hear Jen, those online maybe, and for the recording later, the question was in terms of from a strictly SimWars perspective, what is the level of help that you're going to get if you do an ISBAR handoff? So for example, and I think probably a bunch of you so without realizing it, you guys have been doing ISBAR more or less the last few weeks. And you may have noticed there's been a few times where you guys have asked for help and we haven't given it. So I think week one, everyone's like, can I get a chest x-ray? Absolutely. Is a chest x-ray back yet? Nah, radiology's backed up. Sorry, they're really busy. Or I think in some of the BLS scenarios this week, it's like, oh my goodness, we called an ambulance, is the paramedics here yet? It's like, yeah, they're getting a coffee at these hands. They'll be right there. So, too early. So, in terms of the amount of help that you're going to get at SimWars, there may be, again, certain scenarios that you will get that help that you're asking for to help clinical decisions, and there will be other scenarios where you may not get everything that you order in time. For example, I think there was a scenario a few weeks ago where we gave you a pneumothorax. A bunch of you ordered a chest x-ray, which is absolutely the right thing to do, but we didn't give it to you. And the reason is because pneumothorax is something that is diagnosed clinically, so you don't need that chest x-ray. If you're calling someone, for example, for a consult on a patient, you need some help. It may depend. We may give you a little bit of a nudge if you haven't done something that maybe will help you out a bunch in the scenario. If you're calling for example, the example that Jen gave is we have a friend from this team last year that kept calling anesthesia, and anesthesia wouldn't come. Called, and that patient is deteriorating and they're not doing well. And again, sometimes it's about, okay, we will have someone play anesthesia and get in there, and sometimes we won't, and we just want to see how you guys are able to react and deal with the desaturating patient in those moments. You know, so a lot of the things is, and this is another thing too, is that sometimes before the 10 minutes is up, you may have done all your clinical management, you may have referred them off, and you're just waiting. So there's a lot of just kind of there's a lot of chilling for maybe the last 2 minutes. You know, we want to see how you chill in those last 2 minutes. Are you able to just keep your cool? You guys done everything that you have to do. Are you able to keep the patient stable before you transfer them on? So again, very scenario based, but just because we are giving you help or not giving you help is not necessarily because you're doing something right or wrong. That's just how the scenario is designed to go. Any other questions?
It's not about this lecture, it's about next week.
Yeah?
You said that we're going to be assigned teams, like, we're going to know them beforehand.
Yes, so the question was just a little bit about internal comp teams. So again, if you haven't, sign the form before midnight on Wednesday. After everyone has signed that form, we will begin to formulate your internal competition teams, which will be very similar to the practical sessions in the sense that you will be mixed years, mixed experience and everything, based on everyone's availability. Like some people are only available Thursday, some people are only available Saturday. And we will give you these team members in advance. And the idea is we are assuming that you're going to want to get together with your internal comp teammates and meet up at least once or twice before the internal competition actually is, so then you guys can formulate a little bit of a plan of how you're going to approach things and do that knowledge sharing that we're talking about. So yeah, once we have everyone's contact info in and everyone's registered, we should be giving you those teams shortly, and we'll be in contact with you guys directly about that.
How many resources are we doing in internal comp?
In the reset, so the question was, how many sims are you guys doing in the internal competition? And the answer is you will be doing 3. You will be doing 3 10-minute scenarios back to back with your teammates. So that's another real thing, is that if you do your first scenario and it goes really badly, don't worry about it, brush it off, you've got 2 others. So the idea is we understand that, you know, people have bad days, people have like, you know, a non-ideal sim. You've got a lot of opportunities to show us what you got over that day, okay? Any other questions?
Can a patient die?
Can a patient die? Absolutely.
Not in real life, you know.
In SimWars, absolutely. So the question was, can a patient die in SimWars? And the answer is yes. And I think a bunch of us had said this to a lot of groups, but maybe just in case not everyone's gotten this message, that, again, Sims are designed to go a certain way. Sometimes regardless, even though you as a team, you're doing all the things correctly, what you're supposed to do, the patient is designed to deteriorate and is designed to pass away. And that's just the reality of the scenario. It has nothing to do with you guys, nothing that you did wrong or anything like that. That's just how the scenario goes. Or maybe we will kill them if something sus happens.
But the scenarios are only 10 minutes. In my experience, you don't pronounce anyone dead in a similar scenario. The expectation is that you continue to attempt to resuscitate them until your 10 minutes is over. Does that make sense? Okay.
Turnabout on that is fair play, though. Just because the patient survived doesn't mean you did the right thing either.
Right.
For those online, just because a patient survived doesn't mean you did the right thing either. Again, it goes all ways and all every form.
But keep trying for the 10 minutes that you do have. So, like, call it 3 minutes in.
There's some element of like the gonads on someone that's like, I fucked, they're dead, we're gonna call it 3 minutes. And just thinking that that's what we wanted in the internal competition.
Please don't
If
do
you do
that.
that, that may be such a big dick play that we have to take you.
Don't do it.
Only do this later.
Yeah, another question.
For like a consultation and a referral, could I do like a consultation before the referral? Like do both, or would that be like wasting time? Should I just skip to the referral?
Whatever you as a team decide is the best management of that patient, that you guys are going to feel confident in your decision making and be confident in, I have done everything that I need to do before sending off a referral to someone. Absolutely, you can absolutely do a consult before you do a referral. It's going to like depend on the situation.
In real life, that happens all the time. because our scenarios are longer than 10 minutes in real life, right? So like maybe on hour 1 you call cardiology, and on hour 2 you call back and say, hey, all those labs are back now, if you want to take this guy. In SimWars 10-minute scenarios, like it's probably better to make a call one way or another, but just based on like time limit.
But you're not doing labs in SimWars, right?
So you are, so sometimes you do get labs back, right? So depending on where we want the scenario to go, we may give you labs back. You don't know. And then there's also the idea of like consults that turn into referrals. If you call somebody like, hey, come around and see this guy in the ER, they come down and they're like, yeah, actually, I want to take this guy out of my service. So like, in real life, any of that can happen.
How's everybody online? We doing good? Any other questions in-house or out-of-house?
Quick
You have things to say?
thing to say to everybody.
Come on in. Come down to the mic.
I think we've made this very, very clear. But since Adara's not here, I'm going to make this clear one more time. All right. For those of you online, I think we've made this clear by this point, but I want to make this extra super crystal clear one more time, especially since Adara is not here to do it. Phase 2 is an insane time commitment. If you get picked up into phase 2, we're expecting you for multiple trainings a week. We're expecting you for at least one lecture a week, right? We said, I think in the form we said 5 to 6 hours. It tends to be more than that because teams tend to also want to practice on their own time without us, right? The last thing we want is to put together 3 teams of 6 people and have there be a weak link on one of those teams that drags that team down. This is a team sport, right? If you are signing up for phase 2, you are doing it cognizant of the fact that it is a very, very big time commitment and realistically will probably be the only major extracurricular activity you do in semester 2, right? That's fine. Plenty of people do it. It's a lot of fun. We have fun. We don't eat your entire life. You can still honors in med school while doing SimWars. But it's going to be a big time commitment. So I just want to reiterate that for everybody out there. If you're looking at that and saying, ooh, I don't know if I should do that. I don't know if I'll be able to succeed in school with that time commitment. I have these other things I have to do for the 5 other societies that I'm a member of, whatever. Maybe consider not doing it because it is a team sport. And if you end up being that weak link, you will drag down 5 other people. Does that make sense? Now, the caveat to that is the lecture content for phase 2. I've always been saying this every week. You guys have been asking me great questions about stuff that's just like a little bit out of the scope of what we're doing. And I always say, wait for phase 2. For like this week, it was like dobutamine and epinephrine drips. You guys really wanted to know, everybody wanted to know about dopamine and dobutamine. And I was like, hey, hold up. We'll wait for phase 2. All that stuff, that's still going to be open to everybody. When we're doing the lectures, they're still going to be posted on emstock.ie. If I'm free and we have time, we'll probably still try to do them in person and open it up to anybody that wants to come and hang out, right? So if you want to get that knowledge, but you don't really have the time to do the full thing, there's still a way to stay involved. And you can still get involved as a mock patient. So I want to make it clear that, like, if you don't have that time commitment, that's fine. You can still gain some of the benefits without making that decision. And that's to encourage you to think critically about whether or not you're actually up for that commitment. Copy? You're all. All right, we're done.
Thank you, everyone. You're good to go. Have a lovely evening. And again, if any of you have questions,